love that scarf. Hello, and welcome to the final presentation of the 6th season of our CF Discovery Series. I'm Sue Landgraf, Executive Director of CFRI, Cystic Fibrosis Research Incorporated, and I am very pleased to welcome all of our guests here in the studio tonight and also online. We have a very special program for you tonight, but before getting started, I want to thank Genentech and Vertex for generously sponsoring tonight's event. And as always, we urge you to work together with your healthcare team. It's very important to note that no information presented tonight is intended for a patient's diagnosis or treatment. Tonight's program is being produced by our CFRI Live team. In the back is David Suhu, as well as Mary Convento, who is tracking questions from our online participants. And I encourage everyone here to ask questions of our speaker. This is a great opportunity to hear directly from an expert in the CF field. And online viewers, please click in the chat box on your screen and type in your questions. Mary will keep track and ask them at the end of the presentation. So is everybody ready? Let's get started. Tonight's topic is of vital importance to the CF community. Those diagnosed with cystic fibrosis, as well as their loved ones, face many, many, many challenges living with this complex and difficult disease. Depression and anxiety are very common, and maintaining one's quality of life can be very difficult and elusive. I personally am so very proud of CFRI's programs, which we offer to our CF community to help improve their quality of life. And I say our because I have personally taken advantage of these programs. As many of you know, my adult daughter with CF received a life-saving double lung transplant this summer in July. She became very critically ill, it was urgent, and here she is today with a great set of lungs. So I personally have taken advantage of many of the programs that we have offered, particularly the CFRI Caregiver Support Group. That's really very important. We offer it once a month. And it's helped play a large role in my ability to cope with the extremely stressful events surrounding my daughter's illness. So I can personally attest to the program's impact upon my life. So let's get on with the program. I am very honored to introduce Meg Dvorak, the clinical social worker at the Adult CF Center at Stanford Hospital. Meg has played a key role in the development and implementation of our quality of life programs. She is a member of our CFRI Quality of Life, a Living Legacy to Peter and Kathy Judge Advisory Committee, and is a caring advocate for adults and children with CF. So please help CFRI welcome Meg Dvorak. Come on up. Okay. There you go. It's all yours.
Let me just adjust this down. A little shorter than Sue. Okay, I feel like I'm projecting now. Can you guys hear me?
Yes.
Okay. Thank you for that warm introduction, Sue. And I'm so honored to be here tonight and to talk about these important programs and my role with them. And I'm just going to start by saying, talking a little bit about how this all started, and then I'll kind of go from there. In my first year on the job as the CF social worker at Stanford, I was invited to be a part of this board, the Peter and now Kathy Judge Quality of Life Advisory Board. And at the time, I was new in my job. I was somewhat new to CF. And I had no comprehension of the opportunities that would be afforded to me through this committee, and also just the beauty and uniqueness that is the CF community with all of its layers and micro communities and the way it supports its people. And now, having been in the field all these years, I'm seeing trends emerging, and I'm seeing more and more of the care being shifted outside of the medical settings. And the demand for programs like these in the community is going up every year. So today I'm going to be talking about what started as a regional program, the Peter and Kathy Judge Quality of Life program, that sparked a multitude of programs now offered nationally. So every great program always has a spark. That spark is either a person or an idea or a theme. For this particular board, it was this patient right here. His name's Peter Judge. He was a fun-loving guy with CF, and he was treated at Stanford for many, many years. He was very much loved by not only his family, but his roommates, his friends, and his caregivers at the hospital. And these are some of the adjectives that describe him. And I think the picture just says it all. Look at that smile. Look at him. He's just full of life. And so what happened was he was in his 40s, and he was declining, and he became very, very ill. He was admitted to our ICU, and unfortunately, he passed away in our ICU in 2006. And it was a very traumatic time for his family. And at the time of his passing, they had to withdraw care. And his family noticed that all of the professionals were standing outside of his room, but just the family was inside the room. They were giving the family space, but they were all standing outside, just either crying or holding back tears. And the family said, they opened the door and they said, hey, if you love Pete, come on in. And so they just opened the doors and everybody came in. And in that moment, the family knew they had to do something. They had to leave a legacy behind for this community that deals with this heart-wrenching disease day in and day out. And so what they did was they started this board. And it initially started at the CFRI conference in 2006. I don't know if any of you remember that, but they didn't just want to, start from scratch. They wanted to do a thorough needs assessment to determine what is quality of life. They wanted to really accurately define that. And they had some focus groups. They had semi-structured interviews at the conference. They had some people in roundtables. And what happened was they narrowed it down to 3 broad categories to define quality of life. One is interpersonal connectedness, which is the ability to develop and maintain relationships, to love and be loved. That was very important to people. The sense of security, which is all the things that a person needs to really survive in the world: an income, a car, a place to live that's stable, some money to spend on things. And then last but not least, emotional well-being, the concept of having fun, of being fulfilled, of being able to have hobbies. And just in general, the ability to maintain a high level of participation in life. And I read the report that they had, and I found it most striking that a lot of people were, the concept of time was something that was equally precious to them, but also a harsh taskmaster when it came to getting all the things done for your CF while also trying to have fun and trying to live optimally, and that just constant, impossible balancing act that is living with CF. So in the beginning, we had a very small committee. They wanted to comprise it of people that represented different areas. So they wanted professionals, they wanted a physician, a CF physician, they wanted a caregiver that was a mother of a CF adult, social worker. So we had a broad range of people, similar to like what you'd see on a multidisciplinary CF team. And we all just tried to brainstorm about how we can develop programs. And the program that we were most proud of at the time was the counseling program. And we partnered with a local community center called the Community Center for Health and Wellness. And we were able to set up a counseling program there where we could train their therapists intensively on the disease of CF and all aspects of it. And then we developed brochures, and patients could go to this counseling center and get free counseling. Or very low-cost counseling. It was all sliding scale. At the time, it was called ITP, Institute for Transpersonal Psychology, which then turned into CCHW. There was also a very, very small social worker fund. The fund was managed by the Department of Family Medicine. The funds were very hard to get to, and people had to actually apply for the funds and wait and then get reimbursed for things. Not the most user-friendly model for CF. And we always had strong ties to CF. As you can remember, we started the whole thing by the needs assessment at the conference. So just to look at the complications that can arise as a person that ages with CF. I'm sort of going to go into a little mental health series here, and then I'm going to go back to the community programs. But this is slightly dated data from Port CF, but it just shows how the complications increase over time. If you look at the red and the orange lines, the red is depression, and the orange is the development of diabetes. And you can see that between ages 35 and 44, it's almost at 50%. And many, many patients have told me that the CF is a piece of cake compared to the diabetes and its management, and that adds a whole layer of stress and anxiety to medical management. And you can see that as a person ages with these types of complications, that the risk of developing a mental health problem increases. If you're watching this or you're here, you've probably already heard of the TIDE study. It's a behemoth study that was just published a little bit over a year ago in 2014. It stands for the International Depression Anxiety Epidemiological Study. This looked at over 6,000 CF patients, parent caregivers, and they were given tools to assess for anxiety and depression, as well as they looked at other measures that linked the mental health to the objective health outcomes. There's no other study that I know of, at least within CF and probably in other disease areas, that compares at all in terms of size or study design to this one. So this is really the end-all, be-all study. This is some of the data. Again, this is probably review for most of you, but you can see the significant results here. 19% of CF adults screened positive clinically for depression, 10% of adolescents. CF patients 2 to 3 times more likely to develop depression or anxiety or a mental health condition compared to the general population. And probably the most significant result, look at the moms. 48% of moms have anxiety. So we're going to talk more about the moms in a bit. Probably the most compelling data from this study is just the more objective measures that they looked at and how the mental health translates into worsening health status for the individuals and poorer outcomes in general. Decreased quality of life, increase in respiratory symptoms, more frequent hospitalizations, higher healthcare utilization. The concept of adherence is very elaborate and very complex, and it can mean a lot of different things. It could mean not taking your medications or doing your daily therapies. Also, a person who's depressed or anxious or having problems is probably not likely to come to clinic as often. And so that can cause a lot of strain with your CF providers, and then it just tends to snowball into larger problems because the person just doesn't want to come to the hospital as often. This is a snapshot of that publication in the journal Thorax last year. This study just increased awareness of mental health throughout the CF community, and it really got the CF Foundation to focus more on mental health platforms starting last year. One platform, which I'm going to describe in a bit, is the new mental health screening guidelines that were implemented last year in all CF accredited programs. Another thing to note is that the authors of this study did the first ever plenary session at NACFC focused solely on mental health. And the title of that was called "There is no health without mental health." Also, we're seeing more and more at NACFC, which is the big conference for the providers, more sessions devoted to mental health at non-social work sessions. So professionals across all disciplines are starting to wake up and recognize the profound impact of mental health. So starting last year, as I mentioned, all CF centers are required to screen CF adults ages 12 and up and parent caregivers in pediatric programs. an anxiety and depression screening during a well visit. So this is a minimum of once a year, but there is no maximum. So if a person needs continued screening, we can continue to screen them, but they're required just once a year. We try to do this in the first quarter of the year, and then we can kind of monitor how they're doing throughout the year. There is a question about suicide on the depression screening. So if that answer is positive, we have also a suicide screening that we give, and that's based on best practice. Based on the results of the screening, if it's considered clinically elevated, we provide counseling and we offer referrals to the person. And then the most important thing is the bottom, the appointment of the mental health coordinator in CF programs. This is a brand new thing, just came out probably 6 weeks ago, and the Cystic Fibrosis Foundation is offering seed money for CF programs to appoint a mental health coordinator. The seed money is good for about 3 years, and then they're hoping that this will sort of take off in the programs, but you have to apply for it similar to a grant. And what this will do is provide more seamless coordination between psychiatry and CF programs. And this will look different in every program, but for Stanford, we've applied. And what we're proposing is an embedded psychosomatic psychiatrist in our clinic to help do the screening, to track the scores for the screening, to input these things into Port CF, and to really streamline our approach and provide immediate assessment and intervention in the CF clinic. So these are the mental health screening tools. The GAD-7 screens for anxiety, and the PHQ-9 screens for depression. You can see that they're very brief, they're succinct, they're right to the point. They're in pretty plain language, so it doesn't take very long to fill them out. Most patients have been very open and accepting of these new guidelines. And based on the score, there's a cut point, so any score that's over 10 is considered clinically significant score, and that would be grounds for referral and education. What we're hoping to do is, if we get this mental health coordinator position, to get this down to a science and get these tools on tablets and be able to track them and look at other data and maybe do some publishing around the data that we see. So shifting back to the community programs, I just talked a little bit about the mental health and then the screening, and now with all these programs across the country screening, we're going to have a lot of people that we didn't know before, but are now showing up as depressed or anxious or possibly suicidal. And where are we going to send all these people? There's not enough programs right now to support all of the need that's there. And as anyone who's probably tried to set up counseling or psychiatry for their loved one with CF, or if you have CF and you've tried to get this, it is way easier said than done. These services are separate. They're a separate entity. The insurance even separates it. There's a different number that you call on your insurance card. And trying to see a provider that has any expertise in CF is very challenging. So we wanted to, with all these guidelines and the new emerging trends in mental health, our little board, our Peter Judge board, wanted to expand our programs from regionally to nationally. And so at that time, last year, 2014, we merged with CFRI, which was a great move. And we were able to secure a generous grant from Vertex Pharmaceuticals to broaden our programs to the national level and hopefully become a model for other programs and communities. So I'm going to describe in the next few slides our multi-pronged program to address the sort of holistic needs of the CF community. And our new program is called Partners in Living. So just to start out, we'll talk about the counseling program. As I mentioned before, counseling is very hard to set up on your own. It's costly, Insurance often doesn't cover it. There's a lot of barriers in seeking counseling. And so the ability to get counseling within the CF community by a CF-trained therapist is a valuable resource. We had a counseling program where 14 individuals from 8 different states were able to set up counseling and have CFRI and our Partners in Living program underwrite the cost of that. And the majority of these individuals improved in their symptoms after the counseling. Oh, just going back one more. Before the counseling, the individuals were assessed using the tools that I just described, and then they were also given the tools afterwards. So that's how we were able to measure that. And we want to continue to do that with all of our programs, just to make sure that what we're delivering is within the best practice. Another valuable resource, which Sue mentioned earlier, is the CF Caregiver Support Group. This is a support group that meets once a month on the last Tuesday of the month. It's in the evening time, so people who work or have other commitments during the day can get to it. It is facilitated by a CF professional, the pediatric social worker from Stanford. And with the funds that we got from our grant, we were able to make this group have one consistent facilitator instead of other facilitators. When we were doing the group before, it would always change over to a new person. And so now we have some consistency and we have CF expertise. Another thing we're able to do once we merged with CFRI was we were able to get the group put on teleconference. So there's no geographical barriers. Anyone from any state, anywhere can call into this group and participate. It's not perfect, but it's something that we can offer, and I will discuss our future plans for this group, but we'd love to get more of a video component to have more engagement there. Again, the participants in this group are given the same tools, the PHQ-9 and the GAD-7, and improvement was shown in participants. Another program that we're able to expand quite a bit is the patient fund, or we also call it the social worker fund. And this is a fund that's been maintained at Stanford for quite some time. I was able to, once we merged with CFRI, we were able to get gift cards, gas cards. We partnered with local hotels, and we were able to have the funds delivered easily to the patients instead of having the patients have to pay for something and then apply for aid and then get reimbursed. So that was much easier and much better. It reduces stress, it increases adherence, and these gas cards are a way to help some people who would otherwise not be able to get to the hospital for their clinic appointments. And we all know that regular clinic attendance is highly associated with better health outcomes. And this addresses that security aspect of the quality of life program, needing the gas money, the place to stay. And just to illustrate the social worker fund in the real world, most people with CF don't live right near the CF center. Some of them live 2 hours, 4 hours, sometimes 6 hours drive. And patients with more advanced disease, complications, or who are in the hospital frequently, they're at the hospital all the time, sometimes once a month. So imagine the costs associated with driving to your CF clinic and back. And if it's that long of a drive, it's likely that you're not going to be able to do all of it in one day. So those patients often need help with lodging, gas, meals, and all kinds of other things. Patients who are unable to work because of their CF are often on SSI or SSDI, which does not even pay at the poverty line, which is $980 for an individual. So imagine trying to live in California and take care of your CF, pay for the out-of-pocket expenses for this disease, and get to your clinic appointments. For those patients who have other comorbid conditions, such as sinuses, endocrine, that's another clinic appointment too. I wanted to mention Angel Flight here because I use that resource a lot. It's where volunteer pilots can fly patients to and from their appointments with no cost at all to the patient. And this is a very valuable resource. However, once they get to Palo Alto, they have to take a $30 taxi ride to Stanford and then a $30 taxi ride back, not to mention other costs that are incurred for that visit. So I've been able to use the social worker fund to pay for those taxis back and forth for the Angel Flight patients. And for some patients, that is the only way they get here. They have no other way. They don't have a car. They don't have a family member that drives them. Another creative use is we have Visa cards purchased through this fund, and I can give out the Visa cards as needed for kind of random things, like, for example, a college student living in a dorm, no refrigerator, where's she going to put her Pulmozyme? So I was able to help her buy a small refrigerator for her Pulmozyme and other refrigerated meds using this fund. So probably the most exciting program through this, through the Partners in Living, is the MBSR class, Mindfulness-Based Stress Reduction. And this was also created based on the results of the TIDE study. So what is mindfulness-based stress reduction? Also known as MBSR. MBSR is a type of meditation that, when done, can elicit the relaxation response, and it calms the mind, and it helps reduce anxiety, and it has many, when practiced over time, has many long-term health benefits, such as helping to reduce blood pressure, it helps with insomnia, it helps with chronic pain, and a variety of other conditions. So it was developed in 1979 by John Kabat-Zinn, and at the time he was a professor at Harvard, and he wanted to blend his two passions, which were medicine and meditation. And he did that, and he distilled these two things for a more secular audience. And then he began to publish many, many papers that touted the usefulness of this type of meditation. And then over time, over 400 articles and publications have been done on MBSR and its usefulness across a variety of settings. And it's pretty much become mainstream at this point. My son is even doing meditations in his 4th grade classroom. Yes, he comes to class and the teacher says, okay, it's time for your 10-minute meditation, and they start every day with that. They're also doing it in the military and corporate America. I mean, it's so useful, and the best thing about it is that it's non-pharmacological, and you're using your mind as your tool, your pharmacy, your everything, and there's no side effects with that. So our program put on this MBSR class. This occurred between April and June of 2015. And some specifics about the class: it was facilitated by an adult with CF who's also a physician and trained in MBSR. It had weekly sessions for 2 hours, and these were done on Sundays, so people who worked or had other commitments could participate. And the best part about it was all done online. So it was totally safe for people with CF to participate. It was also open to parents of people with CF and caregivers alike. And we had an overwhelming response, 40% more than we were expecting signed up for this class. 28 adults from 10 states. And once again, like our other programs under this grant, the participants were given the PHQ-9 and the quality of life surveys pre and post. And I'll talk about the results in just a minute. There was one day where they did a 9-hour retreat, and that was to really, sink in the skills. And it wasn't just mindfulness, it was yoga and mindful breathing and all types of formal meditative practices. And I had many, many patients telling me how useful the class was, because I had several on my caseload that took the class. A lot of them said that they loved the manual that was given out as part of the class. It was a nice complement to the class, and it helped them generalize the skills outside of the class times and be able to practice them and use them ongoing. So here's the program evaluation. So 18 participants completed the questionnaires, and we saw a dramatic decrease in depression scores from 9.22, which is just below the cut point for clinical depression, down to 3.33, which is minimal or mild depression. And we thought the results were so striking, and we loved this class so much that we had to write an abstract for NACFC. And this is our poster. We not only was our abstract accepted for a poster presentation, but 2 oral presentations at NACFC this year. Clearly, this is a very unique and popular movement. It's very new within CF, and we've just scratched the surface, really. Because the abstracts were due in May and the program was still going on at the time, we really didn't have it. We couldn't quite get it together to measure all the things we wanted to measure. So we're hoping to be able to do that again, if we're able to offer this again. One thing to note was that 94% of the participants in the MBSR class had a significant decrease in depression, with a mean reduction of 5.89. So that's pretty good. The graph here just shows the different participants and their reduction in their score. So another exciting program debut for 2015 was the Mother's Retreat. And that was, this was also done in recognition of the TIDES results, which I mentioned before. The most striking result was the mother's anxiety level, which was at 48%. And so this rejuvenating 3-day retreat in a gorgeous facility in Menlo Park had this unique focus on the mother's journey, on the self, the journey, and the community. And moms from all over the country, but probably mostly in the West, participated in this retreat at very, very little cost to them, thanks to Vertex and our program. And they were able to engage in a variety of therapeutic programs throughout the weekend. I can't even, there were so many things. Soul collage, journaling, telling their story, labyrinth walking, yoga, meditation. They were able to do all these things in this community of healing and love and companionship. And I think everybody left there changed from when they had come. And this is a priority for us. This is something we want to do again and again, and it's definitely on the agenda for this year. And I have to mention the CF Conference, Patient and Family Education Conference, the 29th annual, which is coming up this summer at the end of July 29th through the 31st. And it's themed Riding the CF Wave. And I'm imagining that this has lots of literal as well as figurative references here. So I'm excited to see what kind of program agenda we put together for this. But I've been to this conference before. It is amazing. I like that it has this more intimate feel. It's got a supportive feel. It has more of an emphasis on the patient and the family experience. And we're able to include patients in the conference while also allowing very safe infection control guidelines. This is the only conference that I know of that's educational but also has support groups at it. And every year those groups are offered. It's 2 hours where the whole, anyone who desires can break into smaller groups, and there's many of them, and I think there's even one for CF professionals, which I think is great because professionals are also touched by this disease. It's very low cost, and I would highly recommend it. So just to summarize, the new programs for this year were the MBSR and the Mother's Retreat. And the MBSR class was very, very successful. However, in the future, I think we want to increase the attendance and possibly even break it into 2 different classes, if possible, if we have the funding for that. One for CF patients and one for CF caregivers, because I think the journey of those 2 people is very different, and they might have a different experience of the class. And one thing I didn't mention before was that the class did have a lot of breakout sessions and discussion, and that's how you really instill the practices, is by sort of learning them and talking to your peers and practicing. The individual counseling, of course, we want to continue that. We want to expand that. We need to define a little bit better how we're going to exactly pay for the counseling. Are we paying for a limited number of sessions? Is it sliding scale? We'll have to suss out those details. Another thing is psychiatry. Many patients, because of insurance or other issues, are not able to see a psychiatrist, and they may need to for very severe mental health concerns, or they likely need medications. And the counseling is great, but it doesn't, we may or may not be able to include psychiatry. The caregiver support group, as I mentioned earlier, we'd love to expand that, get more participation there, and possibly even get a video component to that, as well as the teleconference, to allow people to be a little bit more engaged in the group. Spanish speakers. This disease is growing. There's more people speaking Spanish that also need these types of support. They need to engage in these programs, so we need to be able to look at ways to reach out to them too. So that's also to be explored. I think using the PHQ-9 and the GAD-7 is best practice at this point. This is what's being recommended by the foundation in all CF programs, so this is what we're going to do as well. It's really good for community programs to be in sync with best practice. And just to continue to develop and strengthen our community relationships, regionally and nationally. And just one update on Julie Judge. So I checked in on her last week. She is in her 90s. She's a 95-year-old lady. She's lost 2 of her adult children to CF. Her husband, Tom, died 3 years after Peter Judge died. So this lady's had a lot of loss in her life. And she has been just a fierce advocate of all of these programs, starting with the Peter Judge program years ago. And right now she's on hospice, but she's still with us. And she offered to send her credit card up and take all of us out to lunch, because she wants to, she still wants to be a part of it. So I think that just shows how all of these programs just do begin with one spark, one idea, one experience, and they grow beautifully. And that's it.
I know we have time for questions.
Yep, I have 20 minutes.
All right.
Thank you, Meg. This was a wonderful presentation. So the question I have for you, I mean, my daughter actually had a severe bout of depression when she was about 16. And our healthcare provider admitted that they were very bad at mental health. And they recommended, if we had money, to go outside the system and look for a psychologist on our own, which we did. Mm-hmm. So she was in therapy for about a year and a half, and every week. So that was a considerable financial strain on us. Mm-hmm. I think because of the state mandate now that they have to provide every healthcare, every insurance has to provide mental health, mm-hmm. the same way they provide physical health. I think it's probably slowly going to change. Mm-hmm. However, this whole idea, this annual mental health screening, I never heard this before. Mm. And you said it's been in practice since last year, and mm-hmm. the CF Foundation basically obligates every accredited center to do it. Is that true?
Exactly.
Okay.
I don't know if I'd use the word obligate, but they're calling it guidelines, screening guidelines. And now with this seed money for the mental health coordinator, I think that they're really getting behind this, and they're realizing the importance of it. And they're expecting now to have this data put into Port CF, just like the FEV1s and the BMIs and the OGTTs and everything else. So mental health is right up there as an objective measure with these other things.
I just wonder, why did it take so many years? I mean, it's been so obvious for all of us, I think, who have been going through this journey. Now my daughter is almost 26, so...
I couldn't agree with you more, and I think that the TIDE study results just validates what we've known to be true for years, right?
Right.
We've all known this, but finally we have scientific proof with an N size that's huge. It doesn't get any more valid than that. The older studies in mental health within CF have had inconsistent results. Some of the studies have shown that the CF levels of prevalence of depression and anxiety is no different from the community samples. Some of the studies show elevations, some don't. None of them have even near the N size that this study has. So it really was the TIDE study that
And you mentioned that Stanford is going to now implement a new practice where you will have actually a psychologist as part of your team, or that's not, maybe it's not correct.
At Stanford and likely many other CF centers across the country, we have the opportunity to apply for seed money from the foundation for our programs to have a mental health coordinator position within our team to streamline and, sync up psychiatry, psychology, and CF care for seamless coordination. So specifically for Stanford, we would like to embed a psychosomatic medicine psychiatrist into our chest clinic. Probably other programs will have a psychologist or a social worker take that role, but at Stanford, we want a psychiatrist to do it.
First of all, that's a very important thing to go with, because it has been needed. But my question is, if you're in a different CF center that doesn't provide what you're going to provide, will you be able to handle persons who might need help?
Yeah, I think all programs are different, and some programs are big and some programs are small. And so the smaller programs are still required to screen.
Oh.
And so if you're a CF person who's 12 and older or a parent, you're going to get screened. And then based on that screening, the person who gave you the tool is required to provide to you counseling and referrals based on best practice.
Okay, it's a very important
Yes,
aspect that you
and that's why we have these community
thank you very
programs,
much.
because likely if the person has Medi-Cal or Medicaid or GHPP or maybe is uninsured, they can't get any mental health treatment. So they're going to turn to their communities more and more to look for this.
Meg, we have a few questions from our online community. The first question, why do you think mothers have the highest levels of anxiety?
I think that regardless of your age, whether you have an infant with CF or whether your child is in their 40s or 50s, you never let that go. That level of angst for your child and their well-being and their health is so elevated. I'm a mom and I don't have a sick child, but I can only imagine what that must feel like. And I think the mother's job is never done. If you're not helping your child to do their treatments every day, you're worrying about that child when they're going to get sick. And this disease has this huge component of uncertainty.
Thank you. How does one select a therapist? What are questions I should ask?
That's a really good question, and I've had a lot of patients who have tried to get a therapist on their own, either through their insurance or other means, and sometimes they can get a really good one who just they click with, who kind of gets it, or maybe that person has expertise in chronic illness. And I've had other patients say, my therapist asked me how I caught CF, and then I spent 3 sessions explaining to them about my CF, and then they ended up dropping out of treatment because it was a bad experience. So I think that if I had CF and I was looking for a therapist, I would want expertise in chronic illness or CF, ideally, which it's a unique resource. It's very hard to find. This is an orphan disease, and so not a lot of specialists, but they can be found.
Do you know if there are higher rates of suicide in the CF community?
It's not very high. I think it's like less than 1%.
And the last question is, you mentioned your son did meditation. Is there an age limit to participating in the MBSR program that you mentioned?
I think it's 18 and up.
I have a question, but before that, I'll have a commercial.
Okay.
Which is the conference this summer. We are pulling in the speakers now, and one of our speakers is Alexandra Quittner, who was the primary author of the TIDE study.
Well,
So
she's the one who
anybody
did the plenary session
Yes,
at NACFC.
on mental health, and she's very excited to come out. She's presented at our conference about, I think, 6 years ago, and is delighted to come back. And
I'll be
really
having a
wants
front
to-
row seat there.
There we go.
Thank you.
And then another question is that a lot of people asked me as we were coordinating the counseling services was really clarifying the role of the CF social worker. And people who, especially because there's so little reimbursement for mental health services, who didn't see that as an option, and that's why our program was so exciting. But how to best utilize the social worker, because obviously it's quarterly visits. You want to have a connection with people. You're helping them with broader needs as well. So I'm just curious if you could give the capsule.
Well, as a CF social worker, I feel like for some people who just can't or don't seek mental health services, but they might benefit from them, they use me as their ad hoc therapist. And so I do provide a lot of informal therapy in the clinic setting, as well as at the bedside when people are hospitalized. And I use sort of a client-centered approach, and I join with them and I help them set goals, and I help them come up with strategies to live fully with this disease. And I think those conversations just happen naturally when you're doing mental health screenings and you're asking people about all the non-medical aspects of their disease and their life. The conversations just happen naturally. So I would encourage people to engage deeply with their social worker and develop that rapport and that trust that they may need down the road when they're more sick or they develop something that they need more support for.
So given the data that you guys found in the TIDE study between anxiety, depression, and poor adherence, and the desire in the future to link all these screenings into kind of the regular other labs and values that are done for CF patients, is there going to be in the future, or is there kind of now a tie between eligibility for lung transplant or organ transplant and patients' answers on these screening tests?
No.
No?
I don't think so. I think that it's looked at, it's a factor, and as long as the patient is actively engaged in treatment and their symptoms aren't so impairing that they're non-adherent with their medications, I think that the transplant team will likely work with that patient. It's just that the strong correlation between depression and poor adherence is not a good indicator for success after transplant.
Turned on? Actually, it just occurred to me that, do you have any statistics on transplant patients and their mental health after transplant? Like, there's a correlation for people who go through heart biopsies, not biopsies, not transplants, when the bypass surgery, sorry. They tend to be, or heart attacks, they tend to suffer from depression.
Mm-hmm.
So is there some studies done on?
There's been studies done, and I don't have the data on the tip of my mind, but I believe that it's elevated just because of the chronicity of it and the burden of care and all of the tasks associated with taking care of the transplanted organ, as well as the CF that still exists.
So do transplant patients actually get more mental health then, or it's just the same as anyone?
It's the same. Yeah.
Related to that question, because from my understanding, there's sort of the different worlds of the adult CF center and then transplant.
Mm-hmm.
So the mental health services that you're applying for the seed money for,
Mm-hmm.
would those still apply to people who are post-transplant? Are they still under your wing?
Technically, we're supposed to be screening all CF patients, even post-lung transplant, when they come for their annual CF visit. So that falls under those guidelines. What happens is, though, those patients tend to not come back to CF clinic. Some do, but oftentimes they're just so enmeshed with their transplant teams, and they're so busy with their transplant, and they're already followed there, that they tend to have poor attendance back in the CF world. It makes sense. Are we done?
I think.
Okay.
Thank you, Meg.
You're welcome.
This is phenomenal. Thank you so much. That really was spectacular. It's just wonderful to see our programs up there and having somebody, as competent and caring as Meg be a part of this entire journey for this last year with the programs. And I also want to acknowledge Ed Kinney, who's here today in the audience. He is also a part of the CF Quality of Life Committee, so thank you, Ed. This was all started with a seed, and Stanford came to us and said, we have this program, the CF Quality of Life program, and we'd like to grow it. And so from that point, we went after funding, and we actually grew the program to add the MBSR. And this past year, it was the pediatric conference and the one-on-one counseling and the CF caregiver support group and the patient fund. And it was all generously underwritten by Vertex. What do we have planned for the future? So we have already submitted some funding requests for next year. We're hoping to expand the one-on-one counseling and the patient fund. The MBSR, as Meg alluded to, we're going after 3 programs this year, 2 for those for individuals that have CF, and then 1 for the caregivers. So we will have to wait until the beginning of the year to find out whether or not those are completely funded, but we anticipate that good things will happen because of the results of this program. It's so significant, and you can see from the results from the MBSR classes, the results from the one-on-one counseling. It really does help with depression and anxiety. And speaking as a mother of an adult with CF, yes, we have anxiety. It is real. It is high. It never goes away, even after post-transplant. And I have to just make one other comment that on the annual visit to the CF clinic, I know of one person who is transplanted, my daughter, who will be coming to the CF clinic because she misses her care team that she was with at Stanford for so many years, Meg in particular. So I cannot say enough wonderful things about Meg. Meg really took this program, and with the committee, it grew it and was very instrumental in creating all of these programs. She was very instrumental in helping us market throughout the nation through the CF social workers listserv. And with all of her patients, she spoke to them about it. And it really, I stress the importance of getting involved in these programs. I personally attend the monthly CF Caregiver Support Group. I see 2 other women here tonight who also attend, and it's very important, and it's helped me a lot. So I know it has helped others as well. And again, I stress that it is nationwide. You can call in, and next year we hope to have video conferencing to make it even more accessible. So even if you're listening to us from Texas or Minnesota, you can call in and be a part of this. But I advocate for mental health services for those in the CF community. It's truly very important. So I would like to thank Meg again. You really were tremendous. Thank you so much. And I'd like to thank all of you online for taking the time to be with us tonight, and all of you here tonight being in the studio. And of course, I would very much like to thank Genentech, who has sponsored this series all year, as well as Vertex. And I would like to welcome you back for next year. So we're now taking a break from the CF Discovery Series, and our next presentation will be on Tuesday, February 9th. And until then, I wish you good health, a great quality of life, and if there's anything we can do for you, www.cfri.org, get a hold of us. We're happy to help. All you have to do is get a hold of us. And for those of you here in the in-studio audience, if you could please fill out your evaluation forms and return those, we'd really appreciate it. But thank you from everybody at CFRI. We really appreciate you. And Meg, again, thank you. That was great, Meg. That was great. I got awesome.